stop and so now I have to be more civilized in the way I present myself because it's going into the archives. So I'm going to share screen and begin to go through this particular topic. And what it is, and I know that this is going to hold true with physicians. It's going to hold true with any direct care workers in clinical fields, with people in outpatient, social workers, psychologists, counselors. And it's about the conundrum that is productivity versus quality. You know, at what point are we producing so much that clinical quality goes down? And how do we measure that? How do we know we are expecting too much of our staff in terms of productivity that the clinical quality is going down? You know, I talked to a physician, and I know as a clinical social worker, when I was in private practice or agency work, I met with people for an hour, and which was really about 50, 55 minutes. And after a day with 8 people that showed up, you know, I was tired. I was exhausted. You know, I was kind of, I hate to say it, going through the motions a little bit. And when I was talking to a friend of mine that's a physician, he said multiply that by 4 because he sees a patient every 15 minutes over long shift. And sometimes the office is double booked and they don't get any break. And I'm not going to say that there's people outside of me that have maybe gone through the motions, but I can tell you that, you know, professional disclosure, I have done my best clinical work behind closed doors with nobody looking. At the same time, I have done my most clumsy clinical work behind closed doors with nobody looking. So if I have a clinical supervisor, how do they really know how good a therapist I am and how well I'm doing with clients? So those are just some things I want to bring some light to. Now, the outline for this, we're going to have to go through a primer, and this might be really remedial for some people here, but go through a primer on agency funding, healthcare funding, because that's really built the platform for the burnout that we're seeing among so many clinical folks today. And I know that I was in the field, you know, I'm 63 years old. I've been in the addictions field for about 35 years. And I was working at it in the field for about 10 years before I went to a workshop or I had an executive director that explained to the clinical staff how the agency was funded. And ever since then, I realized how important it is for clinicians to know how the agency is funded, what billable services are, what some of the key terms are, because it helps make sense for the productivity requirements that we're seeing today. So we're going to get a little into the purchase and service model. How billable units must be balanced by quality of care. And to do that, why we have to start tracking patient clinical outcomes rather than clinical outputs. And clinical outputs are things like number of units provided, number of IOP days billed, number of assessments completed, number of, amount of pharmacy utilization, all those kind of things. What we don't ask a lot of in our reports is, especially in behavioral health, did the patient get better? Were the symptoms reduced? We know all about everything that we can measure by billing software. Number of units, number of services, completion of treatment, non-completion of treatment, we could get there. But when it comes to actual symptoms reduction and do people get better, we're failing as a field with coming up with universal measures for that. And going to look a little bit about research on a relationship between documentation and productivity requirements and how that relates to compassion fatigue and staff turnover. So we're going to get a little bit into objectives of, give everybody a rudimentary understanding of funding mechanisms, to realize the relationship between productivity, compassion fatigue, and staff retention, and really have a little bit of discussion and some problem solving of how can we balance productivity mandates with client care mandates. So some key terms. One's going to be purchase of service model, which largely is how we provide most healthcare today. And of course, bear with me for a small moment. I did a presentation last night on political pluralism, and that's the notes that I have in front of me right now. And you guys don't want to know anything about political pluralism, I'm assuming. So, purchase of service model is basically that we provide a service and there's reimbursement for that service that we're provided. Value-based funding, it's a term that looks at incentives that sometimes are offered by a funder that are balanced with some kind of client benefit, that we are going to have some clinical outcome. So if you are a healthcare system, that if you have successful surgeries and a history of successful surgeries, you might get an escalated rate because you are measured as a better healthcare environment. Now, the counter argument to some of that is, will organizations filter clients with best possible outcomes or prioritize those clients in efforts to get that escalated funding? So that's just one of the concerns with that. Going to go into an agency budget for a nonprofit organization and then get a little bit into productivity. So first, fee for service. Health insurance, a doctor or other healthcare provider is paid for a fee for each particular service rendered, essentially rewarding medical providers for volume and quantity, regardless of the outcome. So I know when I was in private practice, and a lot of people on this call know the same thing, different insurances reimburse at different rates. So there's also that. If I have, it's not that your Medicare reimbursement for the same service is going to be the same as a Medical Mutual or a United Healthcare or a Molina. So we have that added issue that not all health insurance or health carriers reimburse at the same rates for the same service. But again, fee for service is based on volume, not on outcomes. If there is a non-for-profit in a county other than Summit, so we'll just, I'll throw it Portage's way for now. Let's say there's an agency that they bill assessments. They're going to get reimbursed for those assessments. Say if you have an individual that has an assessment, doesn't show up for the next visit, comes in a month later, has another assessment, you can see that individual 12 times a year, provide 12 diagnostic assessments. The patient is spinning their wheels, but the agency is making its bottom line. So it also doesn't, there's a lot of duplication of services, a lot of redundancies with the purchase of the fee for service model. Now, value-based funding, like I said, it really is based on quality of care rather than quantity. The trick is in what is the definition of quality of care. Now, productivity, just more terms, is the percent of time a staff member or a producer of revenue is spent providing billable units. Direct staff on an agency budget is those clinical folks who render billable service. Indirect staff is people that don't. Some of the folks that are critical to an organization but don't bring in revenue through billed services is our administration, our executive staff, the IT departments, building maintenance, all those other type of things are really on the shoulders of that clinical staff who brings in the revenue through billable services. You know, I have seen scenarios where there was a physician at one agency that wanted to go to a physician's seminar workshop in Columbus to get 8 hours of CMEs or 10 hours of CMEs, whatever it was. And the agency didn't want the physician to go because they would lose all the billed services from that physician if they went to Columbus for that workshop. So they sought to a local funder for what was called lost opportunity cost, that if they were to send their physician to a training, they need a funder to basically pay them for the losses of billable units that that physician would have. And there's some agencies that have funders that can do that, but others don't. Now, revenue, any funds that are brought into the agency with service reimbursement, grants, other type of revenue, you know, foundation, private donors, a lot of that. But a lot of agencies right now in behavioral health are on a pretty thin margin, and all of their services, all of their revenue is based on the purchase of service model. And then expenditures are what the agency pays in costs. So what we're going to do is math. You know, and I know that in my particular discipline, social work, a lot of people get into social work due to our aversion to all things math. And I can say Nicole and counselors are the same exact way. You know, there's a math aversion there. What?
Holistically, probably, just not with myself necessarily.
Okay, so what we know is Nicole is a nerd that likes math that got into counseling. So she's an anomaly. She's an outlier. Not that I'm judging her entire discipline. What we have is everything that an agency has that costs money. And this is a small agency. So we're going to look at the left of this slide. So overall agency cost, generally with a nonprofit organization, your payroll is your largest cost. Sometimes payroll and benefits is 60, 70, 80% of the overall agency budget. But other things that agencies pay money for is insurance, whether that's building insurance, malpractice insurance, utilities, you know, and utility costs are going up. When organizations had to go to an electronic health record about 20 years ago, those were huge costs. And they also have, you know, attitudinal costs, because it's not just the purchasing of the software and the original computers, it's the upkeep of that software and then now having IT professionals on a payroll that for some organizations in behavioral health, they didn't have for a long time. There's rent and mortgage payments for the buildings themselves, maintenance for the buildings themselves, who shovels the snow, who comes in and cleans, who does landscaping, if there is any marketing, because everybody knows if you put up a shingle on your window, it doesn't mean you're going to get business. You know, you have to let people know where you're at. Is it getting your staff on insurance panels? Is it getting your physicians on different insurance panels? Association fees or trade associations, consultants, certification costs. I'm a little out of the loop on this, but I believe a CARF certification used to be about $15,000. I think Joint Commission used to be about $40,000. And those don't come every year, but when they do, it's something that has to be paid. So we will say every single thing when totaled up at this agency that cost money comes up with $1 million. And that's not random. I came up with this model to make nice even numbers because I hate math. So all of a sudden, so to break even, you need to make $1 million. Now you have FTEs, full-time employees, which at 40 hours a week, 52 hours a year, that's 2,080 hours. So we're going to round that down because I makes my math easier. So a full-time staff member works 2,000 hours a year. You have 10 direct service staff, and at 50% productivity, that is 50% of 2,000 hours a year, not 50% of the time they're in the building. It's 50% of their FTE. So we're going to say that 50% productivity is a full-time staff must spend at least 1,000 hours a year or 20 hours every single week billing services. And your reimbursement rate is $100 a clinical hour. So that 1,000 hours that they bill is $100,000. So you need 10 staff at 50% productivity to generate the $1 million that will allow the agency to break even with its bills. So that's your magic number. 50% productivity equals 1,000 hours each. So 10,000 hours a year at $100 an hour to break even. So now, what happens when healthcare costs go up? There's an agency I'm aware of. It was a mid-size agency, and the staff loved it there. They had people worked at this agency from the day they got to college to the day they retired. And they had some older staff there, but they loved the organization. They loved the mission of the organization. And I believe they had maybe about 70 employees. As they had older staff, that agency had 2 heart attacks and 1 cancer amongst their staff in a calendar year. When open enrollment for insurance came back the next year, it escalated the risk rate for that agency, and their insurance premiums went up about 30%, which is significant. At that particular time, I remember the agency director was able to give all of his staff a pay raise for the first time in several years because we were coming out of the recession, only to have the insurance premiums go up to such a degree that right after staff all got a pay raise, their insurance premiums went up, and those same staff had less take-home pay with a pay raise that they had prior. All because they took care of their staff, and they had older staff that had, like I said, 2 heart attack, major heart surgeries, and 1 cancer in a staff of 60, 70 people. So what do? All of a sudden, the agency cannot offset that additional cost. So they have to put it down on the staff. So now all of a sudden, for staff to get the same amount of money, they raised their productivity rates from 50% to 55%. Now all of a sudden, the agency, let's say something unheard of happens, like the billing software that every agency were gifted by the state, which I'm just going to say is called coexist, just to make something up. And now all of a sudden, the state gets rid of that software that was gifted to agencies, and they have to purchase their own billing software. So now all of a sudden, there's another $10, $15, $20,000 on the agency's bill unanticipated. So now to break even, staff productivity needs to go to 60%. There's building costs and utilities increases if staff ever wants pay raises. And I don't think I'm really making a leap here to estimate that most staff at some point in their professional career would really like to lean into a couple pay raises. But the problem is, if insurance reimbursement rates haven't gone up if Medicaid reimbursement rates don't go up, if Medicare reimbursement rates don't go up, the only way to get pay raises is to increase revenue by increasing staff productivity. That doesn't mean hiring new staff. It means, because that gives you another bill too, it's raising productivity. So all of a sudden, for people that are in community mental health, for people that are in community addiction programs, for physicians that are in private practice, for any number of things, people are literally working harder for the same amount of money as they used to, because of productivity requirements and a purchase of service. So this all begs the question, when does productivity impact quality of care? Now, just an article from Miller. Reimbursement rates has remained stagnant for decades, while other costs for doing business has escalated for years. Any agency executive director knows this. It is a very, very difficult time to be an executive director of a behavioral health agency of late. Prior to the ACA mandate, treatment programs had, a lot of them didn't have electronic health records. Now they have increasing healthcare records and IT costs. I can't think of too many agencies right now that would be able to function without a trained IT staff on board. Healthcare costs have gone up in some, over 100% in some places over the last decade. And sometimes those increases come at the, even though it's increased, you have less comprehensive healthcare insurance. So again, you're paying more for less healthcare. You're working harder for the same amount of money. And healthcare costs are rising faster than wages are. Inflation is going up. So staff really needs those pay raises. But in a purchase of service model, there's no way to do that unless your agency gets gifted with a discretionary grant, and those don't really exist, or you raise the productivity rates. So this is cut and pasted verbatim from a Ohio behavioral health organization. It is a large agency. I'm certainly not going to cite them here, but they offered all of their clinical staff up to a $20,000 a year raise. And this is recently. And if you're a social worker, a counselor, a psychologist, or a nurse practitioner, a $20,000 a year raise, it's a chunk. For a physician, a 20 grand a year raise is a chunk. So it's hard to turn down. So they offered their staff, if you join our incentive program, we will give you an increase in our base salary by $20,000. And a lot of people took that. Now here's the catch. It's called data-informed scheduling, where that agency, it's a community mental health type of agency, said for that $20,000 a year bonus, we will schedule you at 100% productivity. That means if you are working, 8 o'clock till 4, you're going to have 8 clients. You are not going to be scheduled a lunch break. You are not going to be scheduled a bathroom break. You're not going to be scheduled anything. And I don't know if anybody's ever worked at an agency where you're kind of praying for no-shows, just so you could get some work done. Now, there's even an algorithm within where itself that if you have 2 patients that are chronic no-shows, by whatever definition they come up with, it will double book them in the same slot. So there is a chance you can have 9-hour-long sessions scheduled within an 8-hour shift. And there are days where everybody shows up. So I'm just gonna, with this. So if there is a no-show, that's when you do paperwork, that's when you do client phone calls, that's when you do staff consultations, all those kind of things. And I'm just wondering if we can open this up, if people could take off their mics. How do you think this particular policy would coexist with quality of patient services? Anybody have any thoughts on this? Because this is a very real policy with a very real agency in the state of Ohio right now. Anybody have any thoughts?
Well, I'll start. I think in the beginning, and I've been floating around in the background, but I heard your whole talk. So in case you noticed, the beach was empty. But I've been listening the whole time. But anyway, so, I think you might see an initial hoorah, great, we got a raise, work me. And I think that pretty quickly you would find that both burnout and compassion fatigue would kick in, and you'd start to have all sorts of problems. So I think I can see in an initial bolus, you might have a lot of really happy people with 20,000. I would just add to that. I think even those of us who are physicians would be happy with a $20,000 bonus. By the way, you didn't list us, but I would be happy with that. But the problem is that you're right. The trade-off, I would think, is going to be some version of burnout and/or to your question, worse treatment and worse outcomes, because you're going to start to cut corners. You're going to have to do that in order to have sanity. 100% productivity implies you might not even get a bathroom break, right? I mean, so I think in my mind, it would not be, it's not any attempt at work-life balance. It's not any attempt at the quadruple aim, the fourth aim that was added way too late, in my opinion, of staff satisfaction is not going to be there. So
I'll chime in too. I think that also for emergent situations, it doesn't allow for as effective a handoff. So if you have people who being in a situation where there was double booking going on because there was, so much no-show, and then when everybody showed up, if someone's in distress, that really throws things off because you don't want to hurry them, but there's other people there, and maybe you don't have the capacity to be able to have that downtime, some of those conversations, take care of things that are really pressing because there is just no time to be able to do so.
And this is what we're encountering. It's some of our behavioral health organizations today that are working with some of our more vulnerable clients that are in a state of crisis. And we know that going into it. So this is just a quote by William Miller. And for those that don't know him, he is the developer of motivational interviewing. His practice is in New Mexico, and there's a large, indigenous population there, and that indigenous culture has really found its way into clinical practices. And William Miller believes that any clinician needs to have space, and that mental space that allows us to really want to hear their story. Rogers might have called that, try to find a way to get that unconditional positive regard. People say things like, we want to meet clients where they're at. We want to do active listening. Well, what Bill Miller came up with this, and he says this before his sessions to get himself psyched up. No different from how a football player gets psyched up to get violent on the field. He gets psyched up to be calm and present with his clients. So guide me to be a patient compassion, to listen with a heart as open as the sky. Grant me the vision to see through his eyes, eager ears to hear his story. Let me honor and respect their choosing of their own path. He really wants to get himself inside them here. I don't know them off the top of my head, but we know the therapeutic alliance and therapeutic rapport and therapeutic relationships really lends to positive patient outcomes. And if we're too busy to give ourselves mental space to be there for a patient, we're not going to be able to provide as good as services, but we will still be able to build them, whether we're good at it or not. Now, this is just a couple little studies. We know that excessive caseloads and documentation had been identified as key causes of clinical staff departing agencies. And when a staff member departs an agency, that time between they leave and somebody else fills that position is lost productivity revenue that the other staff has to pick up with higher productivity rates, or it's going to come at the expense of maybe staff pay raises at the end of the year. Organizations don't like turnover because it will impact their bottom line. And we're to the point now that we know high caseloads and documentation are having people flee agencies. There was a study that Dr. Gina Song and I did a couple of years ago in Summit County agencies, and we did some focus groups and surveys of staff and executives on this. And we asked, what were the number one reasons for burnout and wanting to leave an agency? And when we asked the executive directors felt it was vicarious trauma and pay. But when we asked the actual direct care workers, their overwhelming response, vicarious trauma wasn't it. Low pay wasn't it. It was documentation and productivity requirements. That is what they overwhelmingly said was the reason for their burnout. Yet, I still see a whole lot of workshops on compassion fatigue and very, very, very few workshops on paperwork reduction for behavioral health organizations. And if we really want to address burnout, we need to start looking at our caseloads and documentations. So our big dilemma, and if someone is a clinical supervisor, that means you're a tweener. A tweener is you are part direct service staff and advocating for them, and you are part management. And you're always in that kind of middle ground there. So how do we advocate for our staff at the same time we push on company mandates and productivity requirements? So we know agency revenues tied to build services. We know the clinical productivity requirements, and whether that is for psychiatrists or whether that is for recovery coaches, clinical productivity requirements have continued to increase. Agency costs have continued to increase. So we're getting to the point that we really need to have this conversation because it's still climbing. And if we don't have this conversation soon, when will we? Now, some potential solutions, and I'm going to turn this over to you guys in a minute, is to develop some value-based funding. But again, we have to come up with what is the value. The first thing we may need to do, and this is, I'll just throw it out, this is just my thought and opinion on this, is until we start measuring clinical symptom reduction type outcomes with our clients, we're going to have no mechanism to know what the sweet spot is. Other than staff saying, I'm burnt out, or staff saying, we have too much paperwork. Unless we could really measure our clinical success rates and start seeing them go down, we're not going to be able to have a true problem-solving conversation and dialogue about where to set these productivity limits. Potentially advocate for reimbursement for some non-clinical services. For instance, we want clinical supervisors to help their staff hone their skills, but we don't allow that service to be billed. So would we be able to begin billing for clinical supervision within some frameworks? Reduce unnecessary clinical meetings, burnout reduction activities. Is it okay? Do we allow our staff to have guilt-free mental health days off? Do we pressure our staff to come to work or work from home when they're sick? what are some burnout reduction activities? And I know that we could teach yoga, and we could teach mindfulness, and we can maybe get some transcendental meditation group going on somewhere. But at the same time, the elephant in the living room is what's causing the burnout. And a lot of it is the productivity and the documentation. So we could dance around that all day long, but our burnout reduction activities might be an organizational paperwork reduction initiative. That might do more to reduce burnout than having people do praying dog in the afternoon at the sunset on a rug in their backyard. Ensure dialogue between business and clinical staff. Does the clinical staff at your agency know how things are being funded? Do they know how things are being billed? And truthfully, the staff might have a better idea of where some system efficiencies lurk than the agency leadership does. So it's going to be important to ensure there's dialogue between that clinical staff and the management staff, and you don't just use your clinical director as the link between those two particular worlds. And if some people have some other ideas, and I'm going to open this up now to dialogue, but this is for you guys. At what point does productivity mandate impact client care, and how do you know? And if you don't know, that's an honest answer too, but that kind of compels us to really want to find out. If somebody's a clinical supervisor, are you required to implement organizational productivity requirements and advocate for staff, and which is more difficult for you? And when I do this with supervisors, a lot of times they say that the advocating for staff is, they like to do that more, but there's a frustration there with it not being heard in the way that it was hoped. And how can you reduce burnout and turnover at your, but if you guys have some thoughts or ideas or concerns, or something in this resonated with you, please share. Because I think the solutions are going to come from groups like this that are really willing to look at this problem in the eye and solve it, instead of dancing around it like we've been doing in behavioral health for about the last 10, 15 years.